Everyone, today we will be talking about preeclampsia. So first we need to know what preeclampsia is, the entire diagnostic criteria, because it's high yield to know for the exam. So in order to know what preeclampsia is, it's a new onset hypertension during pregnancy. So the patient were, was previously normotensive, and then during pregnancy for the first time, the patient developed hypertension. So this is called new onset hypertension, developing hypertension for the first time. And then, but that's not enough for diagnosis of preeclampsia. We need other things. So we need three things. So this is the diagnostic criteria. The first thing we need is that we need to check the systolic blood pressure should be greater than 140. The diastolic should be greater than 90. And there should be two readings, and both of them should be greater than systolic should be greater than 140, and diastolic should be greater than 90 in both of them readings. And those two readings should be at least 4 hours apart. At least 4 hours apart. So that is the first one. So systolic greater than 140, diastolic greater than 90. Two readings should be taken, and they should be at least 4 hours apart. So that's the first thing we need. The first requirement for diagnosis of preeclampsia. The second one is that the gestation. Just look at the gestation. Gestation should be greater than 20 weeks. So that is another. The third is you need either a proteinuria or other signs of end organ damage. So proteinuria is defined. Either of these three would define proteinuria of preeclampsia. So urine dipstick, remember, should be 2+. If they say 1+ in the question, this is not right. You need 2+. So urine dipstick should be 2+. Or if they don't give you urine dipstick, look at 24-hour urinary protein, which should be greater than 300 mg. And even if that is not given, you can look at albumin creatinine ratio, which should be greater than or equal to 0.3. Or if they don't give you proteinuria, just look at other signs of end organ damage that we are going to talk about later. So let's talk then about pathophysiology. So pathophysiology is something we can just draw a simplified diagram here. So what happens in a normal pregnancy is that, let's say this box, this represents the placenta. Let's say this is the placenta. And let's say this is an artery. And this artery, remember, is called the spiral artery. This is called the spiral artery. And normally what happens is that it is really wide. This artery is really wide. And so the blood flow to the placenta is really good. The placenta is really good. But what happens in preeclampsia is that this artery is really narrow. So this spiral artery, it is really narrow. So because it is really narrow, there is really decreased flow towards the placenta. And that decreased narrow spiral arteries, and that narrow spiral artery would result in decreased flow towards the placenta, and that would result in placental ischemia. So, and then placental ischemia, decreased flow result in placental ischemia, and that would actually cause some reaction in the placenta and would result in increased anti-angiogenic factor formation. And those factors can then lead to the endothelium, in the entire body and in all the organs. Just any organ can be affected. So it can lead to the endothelium, and it can cause endothelial dysfunction or activation. So this is called endothelial dysfunction, and then this endothelial dysfunction eventually leads to organ dysfunction, because when, let's say, this is the endothelium and these angiogenic factors, and they are actually causing dysfunction of this endothelium, then we know from histology that around the endothelium, the vessel, we have some muscles, the smooth muscles. So they can then undergo spasm, and when they undergo widespread spasm, that spasm actually causes the hypertension. That spasm also causes decreased flow towards various organs like the liver, like the kidney, like the kidney or the brain. So it can affect any organ. In the liver, it can cause hepatitis, like inflammation, elevated transaminases. In the kidneys, it can cause proteinuria, AKI. In the brain, it can cause stroke. So really important to be aware of this mechanism. This vasospasm, endothelial activation dysfunction causes vasospasm. Vasospasm then leads to decreased flow to these organs. And that vasospasm is also responsible for the hypertension. So hope this was clear about the pathophysiology. Then let's talk briefly over the risk factors. So the risk factors here include obesity, BMI greater than 30, maternal comorbidities like chronic kidney disease, diabetes, chronic hypertension, nulliparity is another. Advanced maternal age is also a risk factor. Multiple gestation is a risk factor. Other risk factors include, for example, history of previous pregnancy with preeclampsia, previous pregnancy with preeclampsia. So let's talk about the signs and symptoms then. So signs and symptoms include a persistent headache that won't go away. Second is like visual changes. There can be blurred vision, and then edema of the hands and feet, hands and face can happen, and then right upper quadrant pain, epigastric pain is common, and then difficulty breathing or sudden shortness of breath and sudden weight gain. These are also important features and signs and symptoms. It actually can also be asymptomatic. So then when we go down from the head towards the head down, then we can see the different features here. So long-standing headache will be there. There can be like blurred vision. Any visual disturbances will be there. There will be spots, and the patient can become very sensitive to light. Trouble breathing is another one. And there will be pain in the upper part of the belly or shoulder, like the epigastric region, right, upper quadrant pain or the shoulder. And then vomiting, dizziness is another, and then swelling of the hands and legs can also be present. So these are all the different signs and symptoms of this disorder. So then let's talk about what will constitute pregnancy with severe preeclampsia with severe features. So if these features are present, then the preeclampsia is termed as preeclampsia with severe features. Severe features. So what are those features? So look at the systolic blood pressure. We know that for diagnosis we need 140, but if it is greater than 160, the systolic, and diastolic greater than 110, that means it is severe. So that's the severe feature. Then platelet less than 100,000 is a severe feature. Creatinine greater than 1.1 is another feature, and transaminase greater than 2 times upper limit of normal is another feature, and severe headache is another feature, and visual changes, pulmonary edema are other features. So these are all the features that constitute a severe preeclampsia with severe features. So if these features are present, then it is termed as preeclampsia with severe features, and it is important to recognize these findings, the different findings, because the management is different. The management for simple preeclampsia, where there are no severe features, and preeclampsia with severe features, the management is different. So that's why we need to know these features. If these features are present, the management is quite different from the preeclampsia without severe features. So, and we talked about, right, the pathophysiology, why these systems are affected. So for the creatinine, we talked about, right, it causes vasospasm, so decreased flow towards the kidney. And here the transaminases, because decreased flow, the vasospasm occurs. Decreased flow towards the liver, they can cause inflammation. Decreased flow, ischemic hepatitis can happen. So then, and the platelet mechanism is a little different. It's because let's say this is the endothelium, and then this endothelium becomes dysfunctional. And when it becomes dysfunctional, the platelets, they will come here and they will bind here. They will form the microthrombi. And this leads to consumption of these platelets, and this consumption then results in decreased platelet count. So that's an important finding as well. One of the severe features. So let's then talk about the complications of preeclampsia. So the first is HELP syndrome. So what is HELP syndrome? HELP syndrome is H for hemolysis, and E for elevated liver enzymes, and L is for low, and P is for platelets. But why does all of these features occur? So let's talk about this. So just like we just talked about the reason for the low platelet count is pretty similar. So endothelium gets dysfunctional, and this leads to the platelets kind of binding here, and it results in microthrombi formation, leads to consumption of platelets. The low platelet that would be the reason for the low platelet. And then we have, as we know, that there are red cells that are floating around in the vessels. So as they go through this microthrombi, they can shear, and that actually results in some sort of cells called the schistocytes. And schistocytes are helmet cells. They look like helmets because of the shearing as they cross the microthrombi. And some of these cells can then undergo hemolysis, and that results in the hemolysis in the HELLP syndrome. So in the hemolysis, we'll have elevated LDH, we have indirect hyperbilirubinemia. So all of those hemolytic picture will be there on CBC. So on peripheral smear, you will see the helmet cells. So this is also called microangiopathic hemolytic anemia, which also is a feature that occur in the hemolytic uremic syndrome. So it would explain, so the low platelets are explained by this mechanism. The hemolysis is also explained. But what about the elevated liver enzymes? So the elevated liver enzymes was the same mechanism because of the decreased flow, the vasospasm that occurs due to endothelial dysfunction. That causes elevated liver enzymes. Transaminases will be elevated. So then the second is a stroke or MI, basically similar mechanisms. Remember that this microthrombi, these are basically thrombosis. So if we have a heart here and this is a vessel to the heart, and it can cause vasospasm, it can cause thrombosis, just like the platelets can bind and form microthrombi, which can decrease flow to the heart and can cause heart attack. And similar to the brain, the blood flow to the brain can decrease because of the vasospasm or thrombi and can result in ischemic stroke to the brain. Then we have the pulmonary edema. Pulmonary edema can happen because of the increased pressures in the pulmonary vasculature, which can push fluid into the alveoli. And then we have the eclampsia. Eclampsia we all know that eclampsia is just seizures, right? Preeclampsia leading to seizures is eclampsia. Then ARDS is another, where there is, like in the lungs, there is widespread activation of the inflammatory cells that causes pulmonary edema. Then we have the placental abruption. Placental abruption, again, because of the vasospasm. We know anything that causes vasospasm would cause premature separation of the placenta. So let's say if this is the uterus, and this is the placenta that is attached to the uterus. So if anything, and this is the blood vessel, so anything that decreases the flow towards this uterus, towards the uterine wall, it can actually cause separation of this placenta. So that is placental abruption risk factor. So, and we know that the preeclampsia does cause vasospasm, so this increases risk for placental abruption. Then intrauterine growth restriction. So remember, anything that decreases the flow towards the uterus, the uteroplacental flow is decreased in anything that will result in the decreased flow to the fetus, and that can result in fetal growth restriction. So just like here, there's vasospasm, so decreased flow, and then result in fetal growth restriction. So we talked a lot about the preeclampsia, the mechanism, and all of them, but what about the management? So how do you manage preeclampsia? So preeclampsia, the first thing you need to do is just look at the weeks of gestation. So if it is greater than or equal to 37 weeks, and regardless of whether the patient is having severe features or if it's a simple without severe feature preeclampsia, then you deliver. At greater than or equal to 37 weeks, any preeclampsia should be delivered. At greater than or equal to 34 weeks with severe features that we talked about, the creatinine greater than or equal to 1.1, the platelet less than 100,000, the other things like the transaminase is greater than or equal to 2 times upper limit of normal. So these are all the severe features. So if these are present, then deliver at 34 weeks or more of gestation. And then you should control, obviously, the blood pressure. For that, we can use labetalol, we can use IV hydralazine, or oral nifedipine. So these are safe. These are medications, antihypertensives, that are safe in pregnancy. So then, IV labetalol is important to know something about the IV labetalol, is that it is an alpha and beta blocker. So remember, in the question, if they give you someone who is asthmatic, who has asthma, you should avoid labetalol. Just go with hydralazine. If also look at bradycardia, because we know beta blocker obviously would decrease the pulse rate. So anyone with bradycardia, let's say 40 or 45 pulse rate in the question, if they give you the pulse is very low, so avoid labetalol in those population too. So then obviously if there is increased risk for seizures, like if the blood pressure is too much or patient is having severe features, then by all means give magnesium sulfate. Remember, magnesium sulfate is one of the drugs that can trigger myasthenia gravis crisis. So be careful about this. If they put that the patient is myasthenia gravis, then you should be cautious of giving mag sulfate. So the topic is done, and now I'm going to give you one question, an MCQ question, and I want you to take your time and answer that question, and then I'm going to give you the answer and the reason for that answer. So here is the question. So hope you all are just trying to answer this. So take your time, take about at least 1 minute on this question and answer, because I'm just going to go in this video and just show you the answer. So the answer here is B. So the answer is B, delivery. We just talked about, right, that 34 greater than equal to 34 weeks with severe features, we should deliver. So like, just don't think, just deliver. Stabilize the patient and deliver. So at greater than equal to 34 weeks, we need to deliver if the patient is having severe features. So now let's first of all, whenever you get a question about hypertension, first of all, know if the patient fulfills the criteria that we talked about of preeclampsia. So what was the criteria? Greater than 20 weeks gestation. Is this patient at greater than 20 weeks gestation? Yes. So one criteria is met. Then number second is systolic should be greater than 140, which this patient has. Diastolic should be greater than 90, which this patient has. So the second criteria is also fulfilled. Now we need third criteria. Third is proteinuria. Does this patient has proteinuria and urine dipstick 2+? It is. Okay, so that is, remember, if they give you 1+, that's not proteinuria. You need to do 24-hour urinary protein or the albumin to creatinine ratio in order to know if the patient is having preeclampsia. Or if the patient does not have proteinuria, you should look for other features that suggest that the patient is having preeclampsia, any organ dysfunction signs. So here we just calculated all three of them. So all three criteria is met. So it is definitely preeclampsia. So then we need to know if it is severe features or not severe features. And in order to know, we have to just read through the question. So they say right upper quadrant pain, headache. They said WBC is fine. HB is a little low, which can be due to dilution in pregnancy, which occurs. So, and then with the platelets, look at the platelets. Are they low? What are you talking about the platelets? We said that the platelets, if they are less than 100,000, then that is considered as a severe feature. So this then constitutes preeclampsia with severe feature. So preeclampsia with severe feature, 36 weeks, deliver. So now, 24-hour unit protein, like I talked about, is wrong because we already have the proteinuria dipstick, which is 2+. If it was 1+, then we would have done this. Then low-dose aspirin is used, remember, for prevention of preeclampsia. It is not used for treatment if the patient has already developed preeclampsia. So this is just started at 12 weeks in patients at very high risk for preeclampsia. And then indomethacin is started at less than 32 weeks, but it is used as a tocolytic to delay delivery. Here the patient is at 36 weeks, so there is no reason to give this indomethacin. It has no role. And so remember, what is the main pathology in preeclampsia? It's the placenta, right? Placenta is dysfunctional. The spiral arteries are dysfunctional. So you can actually cure the condition by just removing the placenta. Once the placenta is removed, the blood pressure is cured. So that is also an important point to know. So the answer here was B. So hope you like this video.